Hello, my name is David Armstrong, and I'm delighted to have had the opportunity today to talk to you on behalf of the Canadian Digestive Health Foundation about constipation and selecting your laxative. I have provided here a list of disclosures, none of which is related to my presentation. My goal in talking to you today about constipation is that by the end of the presentation, you should appreciate what is meant by the term constipation, that you understand some of the various causes of constipation, that you appreciate the role of diet and lifestyle in treating constipation, and that you are aware of the different types of laxatives, how they work, and when to use them. So starting off with some facts, constipation is actually remarkably common. It affects about 25% of Canadians, and it can affect the young, the elderly, and pretty well everyone in between. In some cases, it can develop suddenly, perhaps associated with an acute illness, and it may be short-lasting, but in some cases, it can be chronic and cause problems over many years. In itself, constipation is not usually associated with serious illness. There are a number of reasons why we develop constipation, and poor intake constipation related to decreased food intake may well improve with increased dietary fiber and liquids. More common perhaps is slow transit constipation, which may need simple, what are called osmotic laxatives or newer prokinetic agents to promote gastrointestinal motility. But the successful treatment of chronic constipation generally requires a combination of lifestyle and dietary changes with or without other medical treatments. And the good news about constipation is, therefore, that there are many options that can provide relief. So what is constipation? Well, firstly, is it a topic of conversation? That's a rhetorical question because, in general, this is not something that anybody wants to talk about. And that's one of the problems. Many people suffer in silence with constipation, too embarrassed to discuss it, either with friends or relatives or with their physician. And constipation is one of the conditions that has been defined by the Rome Working Group on Functional Disorders, but perhaps the simplest definition is that which one can find in the dictionary, which says that constipation is difficult, incomplete, or infrequent evacuation of dry, hardened feces from the bowel. The Rome group that I mentioned looks at a number of different conditions and attempts to define what they are. This is known as the Rome group, and they have met many occasions over the last 35 years to discuss conditions like this, and they have defined chronic constipation as a condition which has been present for at least 6 months before diagnosis, and the features that they describe are more than two of the following: straining, lumpy or hard stools, a sensation of incomplete evacuation, a sensation of anorectal obstruction or blockage, and on occasion the need for manual maneuvers to deal with the constipation, and a bowel frequency of less than 3 stools per week. They also say that loose stools should rarely be present without the use of laxatives, and the definition does not generally include abdominal pain, which differentiates chronic constipation from the irritable bowel syndrome. And one of the challenges with defining and discussing constipation is that physicians or medical practitioners and patients often have a slightly different view in defining what they mean by constipation. And often for the patient, they are really describing a number of symptoms which trouble them in association with the constipation. They're troubled by straining, incomplete evacuation, hard stools, or a feeling of abdominal bloating. Whereas physicians will tend to look more at medical definitions and will often define constipation simply by the frequency of bowel movements, and will consider constipation to be a condition with a bowel movement no more than once every 3 to 4 days. And so it's important not to compare apples and oranges, and for physicians and patients to discuss precisely what are the symptoms that are troubling the patient. Just as a refresher, in general, most of the causes of constipation and the place where stools get held up is the part of the gastrointestinal tract which I've highlighted here, which is the colon. It goes from the bottom left on this picture, just above the appendix, up under the liver, across the abdomen, down the left-hand side of the abdomen or the right-hand side of this picture, and then out at the rectum and anus. And if we think about why constipation develops, one way to think about this is to consider the colon as a conveyor belt, which is basically receiving materials and then moving them along the colon from intake from the small bowel by the number 1, and then around the bowel to the outlet, with the colon acting to extract fluid and some nutrients from the stool as it passes along. And so the way that this conveyor belt works is really determined in part by what you eat, how much food, how much water, how much fiber you take in. It's affected by the microbiome, that is the collection of 100 million bacteria in the large bowel. It's determined by how the colon detects and moves stool along your colon. And then it's affected by how stool exits from the body during defecation. One of the ways that we characterize constipation is not just by the frequency of stools, but also what the stools look like. And several decades ago, Professor Heaton in Bristol in the UK devised the Bristol stool chart, which is a medical aid which is intended to classify the form of human feces or stools based on a patient's description of their symptoms and a description of the stools. And in general, if you look at the table on the left-hand side, you can see that these small, hard pellets of stools or hard, lumpy, sausage-shaped stools are indicative of constipation. Having said that, the other forms that you see on the left-hand side may also occur with constipation if you have difficulty passing stools. And a practical approach to the description of the different types of constipation is that, as we see on the left-hand side, there is poor intake constipation, when patients describe passing small amounts of stool regularly, and this is caused by a reduction in food intake and often a reduction in the intake of dietary fiber. In addition to this, there is what is known as slow transit constipation, and patients will often describe that they never get the urge to go, they become progressively more bloated and distended, and they only go infrequently. And this is often more related to the way that the colon detects contents and the way that it then moves the stools along. And then finally, on the right-hand side, we see what is described as outlet dysfunction, when patients describe feeling the urge to go, but they strain and very little happens. And this is because the anorectal region is not able to pass the stool out and resolve the urge to defecation. There are a number of reasons or associations with constipation, that is, conditions or states that are associated with an increased risk of constipation. Older patients are more likely to complain of constipation, perhaps because of dietary changes or because of decreased physical activity. And the dietary changes often relate to inadequate intake of dietary fluid or fiber. There are some medications that can cause constipation, painkillers, particularly those containing opioids, calcium supplements, and some other medications that may lead to a degree of dehydration. Recent abdominal surgery can also be associated with constipation, and people who have previously been constipated or required laxatives are more likely to become constipated later in life. For many people, travel or a change in lifestyle is associated with the development of constipation, and constipation is also rather more troublesome during late pregnancy. There are a number of other medical conditions which are associated with constipation, and I've noted here the presence of an underactive thyroid or diabetes mellitus, but generally most constipation is not associated with serious underlying illnesses. Occasionally, constipation, particularly if it develops rapidly, may be associated with concerning conditions affecting the bowel, and there are a number of what are called warning signs or red flags. The most common or troubling red flag is the presence of rectal bleeding. A recent change in bowel habit with the recent onset of constipation is of concern, as is increasing constipation symptoms, particularly in those over the age of 50. An increase in abdominal pain, particularly if it is recent or if there are symptoms of blockage or obstruction, is a warning sign, as is unintended weight loss. Anemia, particularly if it is what is called an iron deficiency anemia, and in some cases a change in stool caliber, either an increase or a decrease in how thick the stool looks in the toilet bowl. Finally, those who have a family history of colon cancer should be mindful if there is a change in bowel habit or the occurrence of constipation. And all of these warning signs, these things to look for, are findings or indications to go and see your family doctor. If you do develop constipation, what are the tests that you can expect? Well, reassuringly, in most cases, it's not actually necessary to undergo tests if you develop constipation. And from a physician point of view, the most important thing is what is called a history. That is, your physician will want to know the symptoms that you have, how long they've been troubling you, whether there's been any change in medication, and whether you've had any recent or whether you have any current illnesses that might affect your bowel habit. Your physician may well want to arrange for a physical examination in the office, looking for signs of anemia, and also examining the abdomen to make sure there are no localized areas of pain or tenderness. Sometimes, but not always, it may be necessary to do blood tests, and it is actually quite uncommon to need to arrange for more invasive investigations such as colonoscopy, X-rays, ultrasound, or manometry to measure pressures in the bowel to see whether these are affected by the constipation. So once constipation has been diagnosed, and once you and your physician have determined that there are no alarm features that need to be dealt with, how does one then go about dealing with the constipation and getting some relief from the symptoms? Well, one approach is to consider eating foods that contain probiotics or prebiotics, and these will often soften the stool and ease its passage through the colon. The sort of foods that we're looking at here are yogurt, kefir, bananas, whole grain breads, and perhaps honey. It's also helpful to avoid or limit the following foods or drinks, which will tend to increase symptoms and perhaps increase constipation. So greasy or fried foods that are high in animal fat, foods that contain refined sugar such as candies or rich desserts, and foods that contain large amounts of caffeine, alcohol, or artificial sweeteners may also make symptoms worse. Perhaps more important than these is to ensure that there is adequate consumption of healthy liquids. One may want to aim for the equivalent of 8 to 10 glasses of liquid per day, and that can be anything really. That can be water, juices, milk, or soup. Many foods already contain liquid, so it's not necessary actually to drink 8 glasses of water per day if there is sufficient water in other foods that you're taking. A really important part of managing constipation is to try and develop a degree of regularity in your lifestyle and try and identify a consistent time each day to relax and have a bowel movement, to look at consistent times every day to eat, and if possible, to try and develop consistent sleeping patterns. It's also important to take care of your general well-being. If you smoke, this may be a good time to consider stopping for many reasons, limiting alcohol, and if necessary, adopting strategies to try and manage time and cope with stress so that your lifestyle becomes more regular can also be helpful. It's important to avoid overuse of certain laxatives without consulting with your physician. And one of the key principles for many patients with constipation is to add more fiber to the diet. So what do I mean when I talk about fiber? Well, fiber is an indigestible part of your food, usually derived from plants. And fiber is generally categorized as either soluble or insoluble fiber. Soluble fiber dissolves in water and it keeps water in the digestive system and keeps water in the colon. Often it has a beneficial effect on the microbiome, and the sort of foods that contain soluble fiber include oatmeal, lentils, apples, oranges, nuts, beans, celery, carrots, and pectin from fruits. Insoluble fiber, often called roughage, does not dissolve in water. This adds bulk or roughage that may help move the stool through the GI tract. And the sort of foods that contain insoluble fiber include whole grains, bran, and again seeds, nuts, celery, broccoli, dark leafy vegetables, fruit, and root vegetable skins. The challenge here is that large amounts of insoluble fiber can often lead to increased bloating, and it's therefore important to introduce insoluble fibers, in particular, slowly into the diet so that your body and your colon becomes accustomed to this. So how much fiber is enough? Well, generally what we recommend is to consume about 20 to 30 grams of fiber per day. As I mentioned before, it's important to change the diet slowly and to fiber up over several days or weeks by gradually increasing your intake of vegetables and fruits, ideally with the skin, whole grain breads, particularly cereals and pastas, legumes such as beans and peas, and nuts and seeds. One of the resources that you may wish to look at, and there are many on the internet, is from the hospital where I work. The website there at Hamilton Health Sciences in St. Joseph's has a patient education library, and if you search in there, there are some nice information sheets on the sort of foods that contain fiber and how much each food contains. So, in talking about how to manage constipation up to now, I've talked predominantly about lifestyle changes and dietary changes, including the increase of fiber and fluids in the diet. This will work for many people, but if it does not, there are a number of other solutions that may be considered. These are treatments that can be bought either over the counter or they may be prescribed by your physician. These pharmaceutical solutions include laxatives, and laxatives fall into a number of different categories. They may be bulking agents that increase the amount of fiber in the diet, things like methylcellulose or psyllium. They may be stool softeners, for example, Colase or Docusate. Very commonly used because they're often quite gentle in their effect are what are called osmotic agents, such as lactulose, milk of magnesia, and polyethylene glycol, PEG 3350, Restoralax, Laxative, Miralax. There are a number of different names, but what all of these do is to trap extra fluid in the stool so that it doesn't become hardened and it doesn't slow down transit. In addition, there are what are called stimulant agents, things like senna, bisacodyl, and sodium picosulfate. And in contrast to the osmotic agents, which trap fluid in the stool, the stimulant agents work directly on the colon to trigger increased contractions and stimulate the bowel to move the stool along. If we look, there are also some prescription pharmaceuticals. The previous ones are all available over the counter. And the prescription pharmaceuticals that are currently available in Canada and elsewhere include prokinetic agents, such as one called prucalopride, or in Canada, Resotran. And there are also what are called prosecretory agents, such as linaclotide, plecanatide, and most recently, tenapanor. So if we look in a little more detail, most of the medications that are used are available over the counter. There are pharmacy products, and generally it's recommended that the so-called gentler products should be used first if dietary and other lifestyle changes do not work. Many of these require regular use rather than occasional use to deal with bouts of constipation, and the goal is to try and achieve a regular bowel habit before the symptoms of constipation develop. The bulking agents that I mentioned, psyllium and methylcellulose, keep water in the stool to add bulk, and it is the increase in bulk and the increase in fluid that then stimulates normal bowel contractions. The next group of over-the-counter agents include what are called emollient laxatives or stool softeners, such as Docusate. And it doesn't really matter whether it is Docusate sodium or Docusate calcium. These stool softeners contain a wetting agent that helps water to mix with the stool, but they can take time. They won't deal with acute episodes of constipation. What they do is soften the stool, and they can take several days before the effect kicks in. Lubricant laxatives such as mineral oil tend to be a little more swift. They too trap water in the stool, but these are really only for short-term use, in part because they can make the stool oily and unpleasant, and in part because their use can reduce the absorption of what are called fat-soluble vitamins, vitamins A, D, E, and K. Moving on, the osmotic laxatives that I mentioned, PEG 3350, which is a white, colorless, tasteless powder, indigestible sugars such as lactulose, and salts such as magnesium compounds. All of these work to retain water in the stool, and most are available without prescription. They work because they're poorly absorbed by the bowel, and because of that, they trap water or draw water into the bowel and soften the stool. They generally have very few side effects, and used in normal doses, they're generally safe for long-term use. The final group of laxatives that are available over the counter are what are called the stimulant laxatives, things like Cascara, Senna, bisacodyl, and aloe. As the name implies, these work directly to stimulate the bowel muscles, which then causes the colon to propel its contents more rapidly. They can be very effective and they can work quite rapidly, but because of this, the doses that are used may sometimes cause dehydration, diarrhea, and cramping pains. So they should be used judiciously. However, it is important to note that there is no proof that the use of these stimulant laxatives causes damage to the colon or worsens the constipation. So used again at normal or prescribed doses, there is no reason why these can't be used regularly for those who have slow transit constipation. In addition to the stimulant laxatives, occasionally it may be necessary to use enemas or suppositories, but in general this is a short-term measure and should not need to be used in the long term to manage chronic constipation. These treatments work by expanding or irritating the rectum, and this stimulates contraction of the bowel, particularly in the anorectal region, and stimulates the bowel to eliminate stool. These can be useful in the short term if the stool is hardened and blocked or impacted in the rectum. But as I said, they're really for occasional use because they can cause fluid and electrolyte imbalance. Moving on, in a small proportion of people with constipation, there are now a number of pharmaceutical prescription agents that are effective for constipation and have been tested extensively in clinical trials. The first group are what are called prokinetic agents, such as prucalopride. This is a prescription medication that improves bowel motility, hence the term prokinetic or promotility, and this triggers the bowel to contract in an organized manner and speeds up the passage of stool and increases stool frequency. The other group of more recently available agents includes what are called prosecretory agents, medications such as linaclotide, plecanatide, and tenapanor. These two are prescription medications, but they work by increasing fluid secretion into the bowel. They soften the stool and speed up stool passage, and that is how they increase stool frequency. As I mentioned, these are all prescription agents, and they have been developed to target specific mechanisms in the bowel and the way that the bowel works. They generally have an excellent safety profile, and it's often better than the medications, and they're better tested than many of the non-prescription medications. And it has to be noted that non-prescription medications are not necessarily more natural than the pharmaceutical agents that can be prescribed by your physician or healthcare provider. And the next couple of slides, I just wanted to highlight a few points that may be helpful when you talk to your doctor or to your healthcare provider. It's helpful for you and your healthcare provider if you have thought about the symptoms that you have so that you're able to describe them carefully. This is very helpful for the healthcare provider in determining how best to help you with your symptoms of constipation. It's helpful to know how long you've had your symptoms. It's helpful to know what you actually eat in your diet and how much fluid you drink. It's very helpful to know what medications you may already have tried from the over-the-counter preparations that I mentioned, and how well each of those different medications worked for you. It's also helpful to know if you have any particular worries, and it's very common and entirely understandable, particularly if constipation has developed recently, for you to be concerned that there is something worrisome underlying the constipation. And many patients, particularly as they get older, are worried that they may have a blockage or a stricture or even a cancer. And if you're able to share these with your healthcare provider, they are often able to address your worries directly as they work to treat your constipation. It's also important to communicate with your healthcare professional about what it is that you want when you're looking for treatment. What is the main symptom that is troubling you so that the healthcare provider can address that specifically? What symptom would you like the treatment to improve? And do you actually have any preferences for treatment? Would you prefer to consider dietary changes to improve the constipation? Are you looking for advice about over-the-counter medications? Or have you tried all of these and are looking for prescription medications? So in today's talk, I have given you a brief overview of constipation. I've told you that constipation is common and it presents with infrequent bowel movements, but also with hard stools, straining, bloating, and distension. Very commonly, constipation is due to decreased intake of fiber and fluids, but it may also be caused by medications, and there may be an underlying tendency to slow transit or even to outlet dysfunction. I've described that increased soluble fiber in particular, with adequate fluids and physical activity, are the mainstay of treatment for constipation. And finally, that there is a wide range of stimulant and osmotic laxatives which are available over the counter or by prescription for use if lifestyle changes are insufficient to help you manage your chronic constipation. In addition, if you have other questions, there are a number of resources available at the Canadian Digestive Health Foundation website. So again, my thanks to you for listening and to the Canadian Digestive Health Foundation for the opportunity to talk to you today about chronic constipation and the treatments that are available for it.